Okay, welcome to Central Safety Group 2021. We're all here on Zoom, thanks to Natasha from FireFlex for the access to Zoom. We are on a tight time frame, so we'll get moving with the presentation, which is being offered by Christina to give us insights in dealing with COVID in the health system, or at least at St. Vincent. So I'll turn over to Christina, we'll get started. If you have any questions, use your chat mode, and we shall try and address those at the end of the session. So welcome to all. We hope that it's going to be a very active, lively year and that we might actually get to meet at some stage. So turning over to Christina.
Thanks, Nan. Welcome everyone, and thank you for having me to probably just really tell you a story about 2020 in an acute public hospital in Melbourne. And share a few of our learnings and kind of our journey and our story. I think probably the best way to start is to have a look at a little video that was made that really summed up the year at St. V's, and then from that I'll pick out some bits and pieces and we'll have a bit of a chat about it. I can't, it was a very big year, so I can't cover everything, but so if I miss something that you're interested in, just ask me at the end, and the little video might give you a few ideas about trigger things, a few things that you might want to ask. Now it goes for about 5 minutes, so I hope that's all right. But it's actually quite insightful.
2020 is a year we will never forget. Yes, it's because of the COVID challenges forced on us by this global pandemic. But more than that. At St. Vincent's Hospital, Melbourne, we will remember these extraordinary times for the multitude of ways our extraordinary people responded. Hard work, meticulous planning, and collaborative problem solving. Physical and emotional resilience, and care for all our patients, residents, and consumers delivered sensitively and compassionately. Each day, everyday activity changing, evolving as the virus spread across Australia, across Victoria, and as it has hovered like a pall over Melbourne. Most of this activity empowered us to reimagine the way we work. Some things we've done will change us forever, and for the better. We've banded together, more determined than ever, to make a positive difference to people's lives. Whether it be homemade face masks for our consumers in community mental health, or hitting the road to reach Melbourne's rough sleepers and street people with the mobile fever clinic, or just being there at the end of the phone line, giving advice to our staff and to the general public. This extraordinary time has recommitted us to our mission to bring God's love, to bring healing, to bring hope. Never has our enduring commitment to compassionate care been more needed and more precious than in these extraordinary times. There have been many, many moments to treasure and cherished memories made. Over the past 7 months, there have been times when we felt disheartened, tried, and tested. But we've stood together, worked together, struggled together, overcoming hurdles and leading with integrity through our service to our city and our state. We've been there to lend a supportive hand through the community in a multitude of ways. Temperature testing and looking after people's mental health and well-being in high-rise public housing towers under lockdown. leading on the ground, saving lives in residential aged care, and visiting the hundreds of people we kept out of hospital by caring for them at home. In record time, we created the model of care for 4 inner city facilities designed to minimise the impact of the COVID surge on the homeless and people at risk of homelessness. Safe places to self-isolate, quarantine and recover from the virus. Our service of the poor in the tradition of the Sisters of Charity is core and enduring to who we are. It always has been our priority. It always will be. As a hospital, we embraced new and innovative ways to meet increased demands from an anxious and concerned community throughout the waves of COVID-19. Thousands of people tested at our fever clinic. Hundreds followed up each day by Health Monitor. And the security and connection offered through telehealth and our virtual visitor program. In just 3 short months, we commissioned St Vincent's Hospital on the Park. Our newest inpatient site enabled some of our main hospital floors to pivot into COVID care. This year, our clinicians and researchers...
I'm just going to stop it there because that kind of gives a bit of a summary, I hope, of the work that we were doing. And I'm going to stop sharing and then start sharing again. And I've got a little PowerPoint that we go through as well. Share. How's that one? You can see that one?
It's looking very good, yes.
Yeah, cool, great, okay. So I just thought the video kind of shows in action some, you know, some of what we were doing and what we went through. Just for people who don't know, St Vincent's Hospital, Melbourne, it's been around since 1893. It's one of the 5 tertiary teaching hospitals in Victoria, 7,000 staff. We take patients from our local catchment, but also we go beyond that and we get quite a lot of regional patients coming in, and from Tassie. We're the largest metropolitan provider of care to rural and Aboriginal Victorians, that's in Melbourne. We've also got correctional health, we do work there, and a range of community-based mental health and inpatient services, clinical education and research, and I thought I'd just put in our health, safety and wellbeing department, 10 EFT that covers OHS wellbeing, emergency management and injury management. So that's just a brief snapshot. I just thought what I'd do now is we'd just go through a bit of a journey, having a look at what happened. So as we move through the different waves. So initially with, you know, when COVID really hit, or before it hit Australia, but then when it did, the main focus of the hospital was to develop a clinical management plan. So how we were going to manage COVID patients in our hospital, and you know, really the experts, the clinicians, the infection control and prevention team and the infectious diseases team were the main ones who set up that plan. One of the things for us and for keeping people safe was, and I don't know if you can all remember going back to February and March, but the amount of information that was in the media and the amount of speculation and rumour and all sorts of things about what COVID is and what it isn't. And we found that our staff were reacting to that. So we asked, or our CEO asked for a single source of truth, that within the hospital we would have one single source of truth for information for staff, and that the information from that would come from reliable sources. So we set up a little COVID-19 button on our intranet, and were able to put in a range of information for staff using that, based on that. So you'll see some preventing COVID exposures. That one, we had health and wellbeing as well. So our health and safety linked into a number of those. I'm getting a bit of squeaky feedback. Is everyone else getting that too, or is it just me? Is it gone? I think it's gone. It might have been your audio, Nan, feeding back. Okay. So then early on, one of the very early things for us to do, which I think was all workplaces, was to move to working from home in March. We have 1,600 staff set up to work from home. So the department set up a very short video on how to set up, safely at home. We took our already prevalent, already available working from home checklist, and we adapted that to actually not being a tick off checklist. It wasn't a checklist, but it was a guide of what to do and the steps to go through. And the end of that and the beginning of that said, if you have any issues, get hold of us. The idea was that if we had 1,600 of these checklists coming back to us ticked off, what were we going to do with them? So what we did instead was set it up as a kind of a self-help guide with an email that people could contact us if they needed to. And that seemed to work really well. And if people did ring us, it was take a photo. Get someone to take a photo of you, how you're sitting at home, and we'll help you work through it. And we had very few come back to us. And in fact, in terms of incidents at home, over that whole time, we had very few incidents from home. So I think our staff have done quite well there. As we move through, the hospital shut its doors on the 28th of Feb. We closed doors, we restricted access into our different hospital buildings only through a smaller number of doors than what we normally do. And we did set up some temperature testing and checking at the doors. So for a period of time, we had no visitors at all in the hospital. And throughout the year, that's gone up and down depending on what's happening with community transmission. We set up a COVID hotline as well. So part of that single source of truth was that we set up a hotline for our staff to call, and they got information from people who had access to accurate information. So again, a single source of truth for people. We set up the fever clinic. You saw that in the video with the line of people standing outside the building. We're able to convert part of our outpatient clinic with its own external door to use as the fever clinic, and that's still there at the moment and still operational. Our fever clinic staff and their PPE, we'll talk about that a little bit later, and that's changed around as well. We also set up telehealth and were able to empty, you'll see behind here, empty outpatient clinics. So we were able to move most of our outpatient clinics to be telehealth. And it was a system we already had in place, and it was just about expanding that, educating and providing people with the equipment that they needed. So within this wave one, health and safety, our main focus was really on the working from home and getting people set up at home. Like I said, our infection control and infectious diseases team was setting up the clinical workspace. And so they did that bit, we did our bit, and it was about, I suppose, sharing the expertise. You'll also note that in the video we were talking about setting up some external facilities as well. And I think that was one of the most challenging things. Whenever I have been involved in refurbishment of facilities or, it's been months in planning, but this was something that we had 8 weeks and 12 weeks in which to do. So the first one, which was Sumner House, is a 43-bed residential aged care facility. It was vacated at the end of March on a Tuesday, and on the Wednesday, we went in to have a look at how we could turn that into a facility for the homeless who were COVID and SCOVID. And I've used the term SCOVID here. I'll just explain what that is. It's suspected COVID. So within the hospital, anyone who was suspected COVID, so they had a temperature or any of the symptoms, was treated as if they had COVID, but they needed to be isolated from everyone else. So SCOVID, it's just the term that I've used now for a year, are in single rooms, isolated single rooms, whereas people who are COVID positive can be cohorted together because they're not going to catch COVID from each other because they've already got it. So it's a different way of setting up a facility. So this residential aged care facility that was 4 stories with a lovely open air atrium down the middle was set up for SCOVID COVID. It was about setting up the workflows, the staff safety, so our risk approach to that, the resident safety, and it was also a joint program with other services. So with Launch Housing, Brotherhood of St. Lawrence, who owned the building as well. It was an 8-week turnaround. It was really short and tough timelines, but we got there. And I think the way that we got there in terms of staff safety was going back to what we all know and using a risk management approach to have a look at what the hazards were and working through and giving them a rating and saying which ones had to be signed up before we opened and which ones we could continue with to manage once we'd opened. So that was great, and that was used by that was used greatly during COVID as well. I think they were full on several occasions. The other one was St. Vincent's on the Park, which people will know as the old Peter Mac, that tower building, and we took the top 8 floors of that building. It was a huge project with DHHS. It had been empty for, I think it was probably about 4 years since Peter Mac moved out. So it was about getting that that hospital back up to speed, making it safe, and it was set up and as a potential COVID step down facility. So the thought in the redesign was that people in here would be COVID. So again, all the workflows for keeping people safe with their donning and doffing procedures, safe places for staff from COVID, was set up like that. We had to buy all new equipment and furniture. If anyone who's worked in health knows that when you go to purchase a new hospital bed, you spend months and months and months trialling beds. We had no choice. We had to get beds for six floors of those 4 wards, and we had to get beds that were available. So the trialling was fairly limited in terms of going online and having a look at the functions of the different beds and selecting from there. I think having been involved in lots of bed selection before, that wasn't, that was relatively easy. The same with our lifting machines. St. Vincent's has a set lifting machine that we use, but they come from overseas and they weren't going to be available. So again, it was selecting a lifting machine that had the functions that we want and that was available for staff to be used, that we could get those in there. So that was pretty intensive doing that, and the outcome, you saw a little bit of the video of showing the wards, beautifully painted, refurbished. Anything that was timber was removed, no fabric with furnishings at all. All the chairs were vinyl covered. Some new vinyl flooring went down, the rest of the floor was refurbed, and it sat there then ready to go and empty for a period of time. So I think DHHS worked out that they didn't need, luckily, we did well and we didn't need those extra beds. And what we've done is we've actually moved some of our rehab wards and subacute wards down to this area, down into here, to give us a little bit more space up on the main campus. So that sounds great, and everyone was excited about going and moving down there, except the place had been set up as a COVID hospital, and what we had was a subacute hospital. So, you know, people went down there, the doors opened and visitors could start coming in, and we had no visitor chairs, nowhere for a visitor to sit, because it was meant to be a COVID facility and there wouldn't have been any visitors there at all. So there's been a few tweaks like that that we've had to work on. But I think the fact that those facilities, two in particular, got set up and have been pretty safe has been extraordinary. The main issue with this facility was some of the flooring. After years and years of detergent and polishing, some of the floors were actually quite slippery, and we've now gone in and stripped that flooring back and recoated with a non-slip surface, and that seems to have resolved those issues. So that was wave one, and then the other things that we needed to set up in wave one was a wellbeing strategy. We had high anticipatory anxiety from our staff. So in wave one, we only had one COVID patient. The patient came in, with other medical issues, they were designated as having symptoms, so they were suspected COVID. They had their test, it came back positive. They were in a room by themselves. Their medical issues were sorted and they were discharged within a day. So we had one COVID patient for one day in the hospital during wave one, and we only had one staff member who tested positive. They were away from work. They had not been in the workplace. It was community acquisition, and they're at no risk to our staff. So one staff member and one patient. So this very high anticipatory anxiety. People were waiting and waiting and waiting for something to happen, which didn't eventuate. There was lots and lots and lots of planning going on. And that anxiety was actually quite high. So we needed to provide quite a lot of wellbeing support around that. The other thing that was set up was, we got lots of community support for our frontline people as well. And I haven't put it in here, but there was some quite a bit of feelings of guilt as well, as people were being, you know, in the media being portrayed as heroes. You know, you're our frontline heroes. And there's our staff thinking, well, we've only had one COVID patient. And so there was a little bit of guilt around that as well, as that being portrayed as heroes, but feeling like we're still waiting for things to happen. So that was picked up a lot with our wellbeing program. PPE, you know, what's an N95 mask? People had no idea. They hadn't realised that we have, you know, had masks in the hospital that we'd used before for tuberculosis and other aerosol generating conditions, but people didn't know they were N95s, and we had, you know, one mask. All of health in Victoria used the one Halyard mask, and everyone used it, and there was no such thing as fit testing. We set up, using our emergency management system, we set up a daily situation report. So if anyone knows the incident command system, where you have your situation reports for emergencies, you'll see the, you know, whenever there's a bushfire, etc., or, you know, major floods on the news, you'll see someone doing, you know, a situation report with information. So we set up a daily situation report for our staff to access, so they knew the key activities that were happening and what was going on. We had our pathology centre lab certified as a COVID testing centre. We did quite a lot of work around physical distancing, so capacities of rooms and 1.5 metre spacing across the hospital. And we introduced temperature testing. So initially with the ear thermometer, but we ended up at our large sites having big thermal scanners. We set up a PPP level guidance, 1, 2, 3, 4. We showed this to DHHS, who then also set up a level system, but their level system was slightly different from ours. Theirs went 0, 1, 2, 3. And we didn't change ours because ours was embedded at that stage. And in hindsight, we probably should have gone to DHHS, because at the end of wave 2, as we know, things kept going. So we kind of stepped out of wave 1, and we started our work in preparation for COVID normal, as everyone else was doing around, you know, May, June. We set up these 5 key principles for preventing COVID-19 exposure in the workplace. And may I say, these 5 principles have held us very strong until now, when this number 4 has changed a little bit. That nothing, you know, really changed for the rest of the year, that we stuck really tightly to these 5 core principles. We and also developed some extra guidance around that, and all of that information went into that COVID-19 spot on the intranet. We, as everyone else did, had to set up a COVID safe plan, so we did that, and again it was based around these 5 key principles. We started recommencing some work that had been put on hold, so a big occupational violence project that we were trying to get underway, and some manual handling work, and went back to our safety business plan and started picking up some of that work again. Simulation training for our medical staff recommenced. We really, we had started PPE training, but that got really ramped up. And again, you know, as I said, I've got 10 people in my team. It was something we couldn't do. We had a big team of clinical educators, and they picked up the PPE training and did a fantastic job of rolling that out to everyone. And also we offered a lot of PPE advice as well. There was a PPE advisory group that OHS and infection control and education and medical and other clinical staff were on. So there we were, quite happily chuffing along, thinking we'd done very well in Melbourne. And then, yes, wave 2 hit us. So what happened with, oh, and also, sorry, just back during this time, we also had some other simulation training going. So because we had some closed wards, because we'd closed elective surgery, we had set up our orthopaedic ward as a practice COVID ward. And staff were going through and learning and working through how they would do their day-to-day work if they were in a COVID ward, using a ward as a simulation. And that worked, you know, seemed to work really well, and people were feeling fairly confident about what they would do and how they would go about their work on a ward, on a COVID ward. So then we had wave 2 hit us. And it really started with, you know, a staff member testing positive. They'd had contact with multiple staff, and those staff were put into 14 days self-isolation or isolation. And I think then it really hit home to us about, you know, how we would manage our workforce during this time if this extended. And it was actually in ED. So once you knock staff out of ED, you can get into a bit of strife. But we got through that. DHHS asked us to set up our own contact tracing team, which we did, using some members for infection control. We actually moved our nursing staff to 12-hour shifts. And that was to manage our workforce. So if you can think, you know, we'd lost multiple staff through 14-day isolation. If we had 3 shifts of staff going through in a day, that was, as opposed to 12-hour shifts where you only have 2/3 of that amount moving through the hospital on one day. So it was really to manage and protect our workforce. Some staff adapted to it really well, easily, and said that they really liked it. They never did more than 2 days straight. And then they had, you know, full days and several days of breaks in between. Other staff really struggled with that, with fatigue. And when we moved into full COVID, the COVID ward staff, I think, were finding it the hardest. So as COVID started moving through the organisation or through Melbourne, we went from using single rooms and having patients in single rooms to a half ward setup that was COVID, to a full ward that became COVID, a second ward, ICU split. We've got two sections of ICU, and one became COVID. And then eventually we ended up with a third ward and even into a fourth ward that became acute COVID. And the only constant thing through that time was change. You know, every day things were changing. You'll see here, I've just popped in a couple of pictures. Here's our, this is our ICU. These are both of ICU, and you'll see that they're wearing different gowns from one to the other. So, you know, as with normal life, you know, things changed. So our linen supplier, someone there contracted COVID, and the laundry had to be shut down for a period of weeks. And so we went from a linen supply gown to needing to move into disposable gowns. And that created an issue, hard to believe, but these gowns here, the linen supply ones, are cooler and a lot better airflow through and around the gowns, whereas the staff found the disposables extremely hot. So when they're in full PPE with their masks, their shields and the gowns, we were getting lots of issues regarding people and staff feeling exceptionally hot. But luckily we were able to get back into our fabric gowns again. You'll see here a number of staff, so physical distancing in the clinical workspace was really difficult. You'll see a number of staff around this bed, and you'll see an overhead lifting machine. So our Move Smart, our manual handling team, spent a lot of time with ICU staff and with our acute ward staff, showing them and making sure that turning patients prone. I think people have heard that people who are really in respiratory distress, they found that lying them prone on their stomach just helped with their respiration. So some really safe turning for turning people prone, including bariatric patients as well. And we didn't have any injuries from that, which was great. As we moved in, certainly wellbeing became a significant issue as well. We've got a well-established peer support program called STAR. And STAR really came to the fore and you know, set themselves up to provide great supports for our staff. So for all staff who are in isolation or tested positive, they're all sent an opt-in text message, personal message from one of our peer support people. We've got 100 trained staff who are volunteers who work in our peer support program, and most of them volunteered to do that. So they were sent a text message to opt in. They could give a call anytime, day or night, to their particular STAR member, and we continued to follow them up if there was no response, to make sure that people understood that there was help for them if they needed it. The contact tracing team were also contacting people every day or 2 days, and they would then contact our STAR team if they were concerned about anyone that they were speaking to who was in isolation or quarantine. Our executive also contacted every staff member who tested positive as well, and asked them how they were going and is there anything that they wanted, anything we could do for them. Hotels for Heroes was set up, which were if people couldn't self-isolate or quarantine at home, safely at home, there were hotels that were set up for them, and a lot of them were apartment hotels, and people found those you know, really good. And then our STAR coordinator also ran quite a few group support sessions via Teams. So our nurse managers, allied health teams, and a lot of our frontline teams just had some group kind of support sessions, which they found really helpful. And the big message was it's okay to ask for help. What we found at the end when we went back and had a look at our stats for our STAR and also our employee access program is that we had a really, towards the end of wave 2 and into our new COVID normal, it was our older long-term staff who were getting support and asking for help and support. And a lot of them were in the manager roles, and they held it all together. And then towards the end, they were all struggling a little bit. So it was great that they, had somewhere to go and they could go and ask for help, and they were asking for help. As we moved through, we had increasing staff infections. We actually had well over 100 staff who ended up being COVID positive. We were asked to provide support for aged care outbreaks. So we had some of our staff going out to aged care, residential aged care. And what we found from that and it was over like a week or 2 weeks of quite intense work there, and it was lots of hospitals were doing that. And when I spoke with other health and safety managers, what we found were our staff were getting contracting COVID from assisting in those areas. And it was, I think you had people from a number of healthcare services going into an aged care facility, which really wasn't set up well for COVID. And so I spent some time with other OHS managers, and we put together an OHS kind of checklist before we go into an aged care, residential aged care, of what needs to be checked off. That initial checklist that we set up has now been developed, taken up by DHHS, and has been developed into an aged care outbreak tool that needs to be used. So each of the large public hospitals have a catchment of residential aged care facilities that they're responsible for. So as part of that catchment, we have gone through, so the ones that St V's have got, we've gone through and done the initial check for all of those aged care facilities. We know what's there, we know what safety things they have in place. And if we do get called out to them, it's just then doing a really short check of what have you got in place right now for COVID. But we've kind of covered off all the rest of the safety issues. In the height of all that, the WorkSafe incident notification changes came in, and that, was a great idea for probably workplaces where there were 1 or 2 infections and they really didn't have the full infection control and system set up. But may I say, I did over 70 of those notifications, and in terms of adding value to safety, probably not. And I did most of them at night. I was doing them at night at the end of the day. It really was a bit of a chore. Health support for housing towers. I think you'll notice that we went out and provided health support for some of the housing towers that were put into lockdown, not the full lockdown, not the ones in Flemington, but certainly some around Fitzroy and Collingwood, and a lot of COVID testing there too. So I said we had increasing staff infections, and we did. And we used the information from the contact tracing team. A large number of us had a look at all that information, and we worked out that we had some key problem areas where staff were getting infected. So the biggest one of all was our staff break areas. So if you're working on a COVID ward, you were donned in your mask, your gown, your N95 mask, your eyewear, often either goggles, or for most people chose to wear a face shield. You were in there, you would come out on your break, you would doff, and then you would go to a clean tea break area and sit with your colleagues, take your mask off, eat, drink, chat, probably not keeping 1.5 metres away, not popping your mask on afterwards. You were talking to your colleagues, you were talking to your friends, and our staff didn't see them as a risk. They saw the patients as a risk, but they didn't see their colleagues as a risk. And we, I would say a number of our staff who contracted COVID, contracted it through those staff break rooms. So we did some, St. V's has a problem solving methodology that we use. So we put that in place and we looked at our staff break areas, and very quickly we mobilised some marquees outside, as we called them, speed dating marquees. They had single tables, single chairs. We set up a set of rules, and there was a set of rules around staff break areas, and the donning and doffing of masks, and making sure as soon as you finished eating that you placed a mask straight back on. And, you know, one of the easiest ways to do that was to make sure that, you know, boxes of clean surgical masks were available for staff in those areas. So we soon shut that down, which was great. Eyewear was another one. In non-COVID areas, people were moving their eyewear on, even in COVID, on and off their heads. So the face shields provided a better way to manage eyewear, and education for other people in COVID areas as well about eyewear. Donning and doffing processes. If people didn't doff in the correct order and in the correct way, what we were finding were their masks were dropping down and contaminating their clothing. So that was, we went quite hard on our donning and doffing process for staff. We introduced spotters. Here's a spotter, someone helping, but also talking them through their donning and doffing process. Physical distancing in clinical areas as well, and that continues to be ongoing, and then cleaning. And the cleaning wasn't so much about how clean things were and was cleaning happening. It was that people weren't aware that cleaning was happening. So we were getting reports to say, I haven't seen a cleaner all day. But when you went back and had a look at what the cleaner was doing, they had been there. So it was just putting up those, you know, the airport toilet kind of tick off boxes to say, I've been in this room and cleaned. And then the other thing was the introduction of the respiratory protection program work as well for our staff. So we were heavily involved in that and in all of these problem solving areas.
5-minute warning, Christina.
Yep, that's fine. Another thing that we did was, as things changed and rules changed, we set up our preventing exposure to COVID-19 in the workplace checklist for all our managers to do. They were structured around our 5 key principles. We use the same tracking and reporting system as we do for regular workplace inspections. We hyperlink to resources in there, and we had 4 different versions. As we moved through, each time something new came in, or we developed the how to set up your staff break area, the next checklist would have that new information. And they worked really well, and our executive liked those as well because they felt they had some knowledge of compliance across the workplace. Just the last, I think this is almost the last one, respiratory protection program. So how we, you know, set that up. You know, we used to have one N95 mask. We used to have this one here. At one stage, you know, we had 10 different masks available to us. We worked out there are 3,000 staff who may wear an N95 mask. We reviewed the risk of those. We determined a priority, and so far we've tested 900 high-risk staff using up to 10 masks. So the fit testing appointments are 45 minutes each, and some staff have to come back and do 2. So that's been a really long process, but we're getting about 94% success with fitting at least 1 mask. And always in this percentage, there are people who haven't come back for their retest. So we're probably around 95 to 96%. And we've just been, we've had new masks arrive today. So some of those people who haven't fitted will come back and get tested again. And then the last one is probably some lessons. What did I learn through all of this? What has health and safety learned? That having a good, simple system will get you through. Use what you have, what you know and what you have. Stick to what people know. People wanted to reinvent things and change things and make up new things. And it was like, no, people know how to do our injury management process. Stick with that. People know how to do the workplace inspection system. Stick with that. And make sure that you tell people about it too, what you're doing. And also a great team. So the health and safety team at St. V's has been fantastic. They're adaptable, they're responsive, and they were very resourceful with what they did. And then the last thing is don't be precious about your work and your area. Use everyone's expertise and skills and work out where infection control, infectious diseases have the skills. You just sit on the sideline and let them do the work. Yep. Or this is our area, we'll do this. We've got the expertise in this. So this is something that we'll do. And then that was the end with any questions. There's so much more that happened to talk about, but I just tried to pick out the kind of the key things and showed you how safety intersected with those.
Okay, thank you very much, Christina. I think your expertise certainly shone through in that presentation, as has been recognised by at least one of the speakers to date. So thank you very much. That's fantastic. I really like the way you actually started with the values of St. V, because it actually is quite unique within the public health system with the sisters in charge. So thank you very much for that. And again, I think
not many sisters left, Nan.
No, but the values are still there. So
values
that's fabulous.
Are very strong, yeah.
And I think certainly what you had, your 5 key principles, the whole keep it simple. I think that certainly was a very clear message. And I think the genuine, honest sharing of those tools with DHS and other hospitals and communities, I think is certainly a credit to yourself and to the St. Vincent's, again, not being precious and working collectively as a community. I think one of the comments from one of the listeners was around the housing towers. That was obviously another whole issue in itself, the same with aged care. And I think we need to try and record and learn from these events, because it certainly is not, it's a matter of when the next pandemic is. So certainly I'd maybe like to speak with you and maybe get some contacts in those other industries so we can try and gather more information, so we've got a broader idea of the high-risk industries which are impacted by COVID. And thank you for your term SCOVID. That's a new one. Yay.
Well, we had COVID, SCOVID and surprise COVID. So some of our outbreak wards, where we had some of our subacute wards, ended up as outbreak wards with surprise COVID. So patients who'd come through the acute system showing no signs, hadn't been tested, got through to like day 14. They'd moved on to a rehab ward, day 14, started showing symptoms, tested positive, but in the 3 or 4 days before that, they had been around patients and staff, and we had an outbreak on our hands. Yeah.
Christina, could you just stop the screen share now so we can open up the gallery? A few people have some questions.
There we go. Yeah, great. Fire away.
I put a question in the chat box, just wanting to know more about what you did in the Housing Commission flats. And sorry, I'm making an assumption here, but was there a high percentage of second languages there, and how did you? I did make an assumption there. How did you manage that?
Yeah, it was one of my team members who did a lot of work there, my emergency management coordinator, who's also a hospital after hours coordinator, did a lot of work there. So what they were doing was really door-to-door testing, door-to-door health support for people, but they also had, there was quite a high security presence at the towers as well, in terms of making sure that our staff was safe, making sure that they had the right PPE, that anyone else who wasn't from the hospital who was there were trained with the PPE as well, and all the processes and the work processes. So it was getting staff out to do that training as well. Yeah. So it was generally
what about
just
the languages, the second languages and the language barrier?
I'm trying to think what they did. They must have had some, oh look, sorry, I can't remember. They would have had some interpreter support. So whether they were on the phone and they were using via speakerphone, they certainly had written language information in other languages, but yes, yeah. And look, I really can't tell you much more on that. I'd have to get back to Barb and ask Barb for information.
Okay, thank you.
Thank you.
Thank you. Yeah. I think there were a few more questions, so I don't want to take up everything.
Christina, hi, Christina. Look, Adrian Glavitz from Hazard Code. Firstly, thank you so much for the presentation. It was really excellent and well thought out. I know personally from experience how seriously you take, firstly, health and safety. Knowing that you previously or you still use LinkSafe for inductions and a few other things. But what I did have a question. Look, I know a nurse that was and is a nurse there currently, who is, and I guess my question's around more around mental health, and that has stemmed from this. So we now know that mental health certainly ties very closely in with, this occupational health and safety systems. She is a younger person, so she's in her early 20s. She was working, certainly when the outbreaks were happening, she was frontline and was stressed out herself, was not seeing family because no one could see family. But she put on a brave face and just kept going to work. Now, she's now suffering from that. I guess, and I saw the plans that you put in place for it, but there are times that people get missed, certainly. I just want to know, now that we've kind of got things back on track, and things will happen, of course, down the track, but how do you keep checking in with people?
Oh, yeah, Adrian, great question. So we are still, doing COVID work. So, and our wellbeing team are certainly now looking at post-trauma with people. We have a lot of staff who are suffering from kind of post-trauma issues with their wellbeing. And so we are providing lots of support as we can, and lots of group sessions for people, individual sessions. Our star wellbeing manager is about to run a big team session for people about resilience and how to manage day-to-day work in the area of post-trauma. It's certainly something that we haven't said, right, everyone's back to normal, because we know that people aren't. And we currently have some issues with high sick leave at the moment, and people leaving healthcare as well. And we know that that post-trauma is there, and our wellbeing strategy is it's done as in a ICS kind of manner. It's your planning, your implementation, and then your recovery stage. And we're in recovery stage at the moment from that, Adrian. And if you're talking to your friend and they really are struggling, every health service has supports, and it's about linking in and getting in with either their peer support program or their employee assistance program to assist.
I guess I just worry about the people that are not saying anything, and that's my worry. She's very shy, and she's a leader, a team leader there as well. I mean, everyone deals with their own problems differently. And you as a provider can only do so much to go, hey, put your hand up if you need something. Or,
let us know if you think one of your colleagues is struggling. We do get a bit of that, where managers will let us know, or other colleagues will say, I'm worried about someone. And again, our peer support program, we can get in touch with a volunteer in their area who can just go and give them a tap on the shoulder and say, you know, I'm checking in with everyone and let's have a chat about how you're going. So there are ways we try and pick up those people, but yeah, you can't go to everyone and force them into a conversation. Yeah.
Okay, well, unfortunately, a fascinating topic, which we'll have to close down because Marina's got to hit the record button and run. So I think we will have to certainly take up some of these key themes in other sessions. And I think I've certainly got 3 or 4 topics I'd like to possibly explore that we'll try and find some other guest speakers on.
Yeah.
Again, thank you, Christina. Wealth of knowledge. I wish we had longer. I think everybody does. We'll certainly put the recording up on the Central Safety Group website, which will be available to financial members. If anybody isn't a financial member, please email Marina at secretary@centralsafetygroup.com, and we'll look forward to seeing you again next month.